This video is about my approach to syncope. And syncope is the complaint that is perfectly aligned with the path of clinical reasoning. Almost always, you'll come to a conclusion before getting any labs. First, I want to start off with the difference between seizure and syncope, and then go to the approach, Women 321 PE. When someone comes in with a loss of consciousness, the first thing you need to do is separate that into, is this actually a seizure, or is that loss of consciousness from a syncope? One is a perfusion issue, syncope. The other is electrical activity issue, seizure. If someone is upright, and one of these things we're about to talk about happens, the perfusion to the brain is compromised. Person falls over, no longer does the heart have to push against gravity, reperfuses the brain, they wake back up. Seizure, total brain electrically discharged. Patient falls over, but that doesn't improve anything. Still electrical activity is firing. So the two have completely separate pathophysiologies, where that also then ends up presenting in different ways. What you get taught a lot about, because it's a holdover from a long time ago, are the things that don't work. Tongue biting, and loss of bowel and bladder. People who poop themselves, pee themselves, and bite their tongue do not help separate seizure from syncope. So what does? Jerking motions do. The post-ictal state, the duration of time, and the presence of a prodrome. The most important thing of them all is the post-ictal state. I used to teach that it was only the post-ictal state that mattered. Now, this time I'm going to give you is not a hard stop. It's a gestalt, it's a feel, because we don't have very good evidence on likelihood ratios. Mostly because the people who report to you the duration are bystanders who are freaking out that someone's fell on the ground unresponsive. So and the patient, of course, they lost consciousness, they can't tell you at all. So the feeling is going to be rapid return to consciousness if allowed to go down versus slow, gradual recovery. If you have a post-ictal state, that is, they are out and continue to be out for less than a minute, or when they finally open their eyes, there's a rapid return to normal, that is highly suggestive of syncope. If, on the other hand, it is a post-ictal state, if they take longer than 5 minutes to come back, or when they open their eyes, they're still not with it, they're kind of looking around, and then eventually, gradually they return, that is likely to be a seizure. I used to say limb motions don't work, but in recent years we've come up with the 20-10 rule. People who have tonic-clonic contractions in an epileptic seizure generally have many of them. And because it is a total brain discharge, those jerks are bilateral. If you have fewer than 10, or they're unilateral, that is suggestive of syncope. Seizures don't have to have auras, but they can. And some syncopes, like vasovagal, have a prodrome. So I don't like teaching this prodrome business because it's really hard to discern. And you have to be careful because you might say, well, if they have a history of epilepsy, dadoy, but people have been misdiagnosed as having epilepsy when really what they had was vasovagal syncope. So don't necessarily use the fact that they've had a history of this to define this loss of consciousness. Most people who have a diagnosis of epilepsy have epilepsy. And if you happen to have somebody who passed out for the first time, just do this exercise. Lots of jerking bilateral always, long time to come back to normal versus less than 10 or unilateral jerks with a rapid return to normal. We're talking about syncope in this. So once you get to syncope, then you can begin this process. The advanced organizer is Woman 321 PE. The reason for that is because the first category has 3 subcategories. The second category, the O, has 2 subcategories. Then each of the subsequent have only one. Thus the 3, 2, 1, and the PE is there so that PE is included. Many of my learners insisted that PE be part of the syncope mnemonic. My challenge to that was, if you have an outflow obstruction of your right ventricle, pulmonary embolism, so bad that it reduces perfusion of the rest of the body, the LV, falling over won't help. Right? The problem with syncope is that your brain's up here. So if you have poorly perfused, then you fall over and it's easy to perfuse it again. If the obstruction is at the level of the heart, they're going to wake up dead. But one patient, presentation was with syncope, woke back up not dead and had a PE. So it's in there. But I don't want you going chasing down pulmonary emboli for a patient with syncope. And what we're going to do here is talk about the type of syncope, relate that to the story and the physical exam that you can do, talk about any diagnostic steps you can do, and then if there's a treatment, talk about the treatment. But we're focusing mainly on using the history, physical, and diagnostic intervention to figure out what type of syncope it is. All right, the mnemonic falls apart at the very beginning because the W is actually two V's, the double V for vasovagal. The vagus nerve, when it discharges, it creates a cardioinhibitory response, bradycardia and vasodilation. Both of those at the same time are going to cause frank hypotension. Vasovagal syncope can occur because of stimulation of the vagus nerve. So how do you stimulate the vagus nerve? Well, the first way to do that is through visceral organs. The vagus nerve is all over the viscera. So patients who have to strain when they defecate or have to push really hard in order to pee, people who cough really hard. Stimulation of the thoracic pressures can stimulate the vagus nerve and lead to syncope. The other way to do that is by stimulating baroreceptors. Particularly the carotids. When a boxer goes for a jaw shot, they're not trying to break the guy's jaw, they're kind of hit him in the carotid in the neck. Because if you have a boxer blow to the things that try to cut off the feedback of high blood pressure, that is, if you punch really hard in the carotid body is going to tell the brain the blood pressure just went sky high, you're about to explode your brain. The vagus nerve says, everybody chill out, let's reduce the pressure. Stimulating that, it happens when you hit it. On board exams, it's like guys who wear their ties too tight, and whenever they turn over, they pass out. The last way to do it is because the vagus nerve is in the brain, you can have psychogenic causes. On board exams, it's emotional females that pass out. Don't get mad at me, I didn't write the exam. But psychogenic explains more accurately passing out at the site of your own blood. So vasovagal syncope can happen in different ways, but there's something unique about each of those. They are situational. And they are recurrent. Usually you can reproduce them. And people who have vasovagal syncope have a prodrome. They know that's going to happen. They feel themselves going out so they can take a seat before they pass out. I've never actually gotten this to work, even though I've made diagnosis of vasovagal syncope. If you do a carotid massage, and you get asystole on the monitor or a drop of 50 points in the systolic blood pressure, you've confirmed your diagnosis. Vasovagal syncope is usually that syncope that says, you know what, don't worry about that syncope, you're good. See you later. So you don't necessarily need to do a tilt table on every patient you think is vasovagal. But if a person keeps coming back over and over again with these syncopes and they're disturbed by it, you want to confirm that it is vasovagal, use a tilt table. The treatment is with beta blockers. All right, the second category is orthostatic. This may come as a surprise now. People who present with orthostatic hypotension present orthostatic. That is, it occurred when they stood up. And the test you should do for this is orthostatic vital signs. You should do orthostatics, not instruct someone else to do them. To do it correctly, you should have them lay down for 5 minutes, take the blood pressure. Have them stand up for 5 minutes, which is really awkward if this is the only test you're doing. You should have them standing between you and the gurney. If they fall on you, you push them onto the bed. If they fall backwards, they fall into the bed. What you should do is walk in, you get in the interview, and you know you're going to do this test, so get them in the position, push the button. Later, stand them up, and continue the interview, do the physical exam. The test is positive if they cannot remain standing for the duration, not 20, 10, 15. What that's for is if they can't finish the exam because they start to pass out, you push them back on the bed and then push the button. And wow, look, the numbers are so low. Don't have the nurse do it, who goes from laying to sitting to standing. That's only an approximation. The reason why we do it that way for nurses is because it's really awkward to stand there in front of somebody for 5 minutes. And when you push the button, it takes a little bit of time, and then moving the position, it's sort of like they've been standing up for like 3 minutes, but really they haven't. They've only been seated and then standing. And as soon as the patient stands up, they push the button. So they're not getting good orthostatics, but if they're positive, great. But really, it's the inability to finish the exam, that is, they pass out on you, that's positive. And make sure, ER, that you do orthostatics before you give fluids. 2 subcategories of orthostatics are just that. Volume down is one of them, which is the 4 Ds, dehydration, diarrhea, diuresis, and hemorrhage. And the other cause of orthostatic hypotension is a dysfunctional autonomic nervous system. Old people and people with Parkinson's have this issue. When you were 18 and you jumped up off a couch, your heart felt a change in the venous return. Blood started to pool in your legs, but immediately your nerve fibers are like, whoa, and everything vasoconstricted. At 80, you try to do that. You still get up fast, you still pool, but your veins are like, hang on, I'm catching up, hang on, wait, and the venous return doesn't catch up. The patient passes out. People with Parkinson's syndrome happen to have this really bad, their autonomics are even worse. Lots of things can cause a dysfunctional autonomic nervous system, diabetes, for example. But where you're going to see orthostatic be diagnosed is someone who is clearly volume down, in which case you give them fluids. Or you try that and they remain orthostatic because they're really old. Old people just need to get up and go slow. Compression stockings. It sucks, but I think their autonomics aren't fast enough and there's not a way to speed them up. These two, M and A, are the reason you admit somebody, because they are cardiac, and the cardiac causes of syncope kill you. The M stands for mechanical cardiac. That is structural heart disease. It presents as an exertional syncope. And because it usually has to do with valves, there's going to be a murmur on the physical exam, especially the elderly. Aortic stenosis. It can be any. And it can also be coronary artery disease, but usually it presents the chest pain, not syncope. So you're going for mechanical cardiac, valvular disorders, exertional syncope that does not occur at rest, hear a murmur, confirm with the echo. And then surgery is likely if the valve's that bad. The A is arrhythmia. Arrhythmias are the syncope that comes out of the blue. It's sudden onset. No prodrome, no idea that it's coming. And generally you don't have any physical exam finding. If they were nice enough to show you their new AFib, that'd be great, but usually they don't. There's no physical finding that suggests that it could be arrhythmia. You observe them in the hospital to put on a Holter monitor, which is observation wearing a cardiac monitor. There's more things you could do, like a loop recorder or an event recorder on discharge. But you're not going to do that for your first time syncope. But the person who you think has an arrhythmia needs to come in because the VTAC that caused them to pass out, because it's the same VTAC that caused them to die. But generally, when you bring someone into the hospital, even though it is arrhythmia, you discharge them the next day without that answer. Neurogenic is problematic because it presents in exactly the same way as arrhythmia. Only it's super rare. So rare that you should not even consider it unless you have a focal neurologic deficit that goes with it. Neurogenic syncope is from vertebrobasilar insufficiency, the back of the brain. What you see on routine syncope order sets is the echocardiogram, observation admission for EKGs, and the carotid ultrasound. Now, some of them are good enough to detect anterograde or retrograde flow in the posterior arteries, but a carotid ultrasound looks for carotid artery stenosis. Carotid artery stenosis does not cause neurogenic syncope. That would cause an ACA or MCA stroke. Vertebrobasilar insufficiency causes you to pass out. That is better diagnosed with a CT angiogram or an MRI angiogram. The problem is that you should not be working patients up for this, and that's got contrast and it's expensive. So you'll see people still get the ultrasound because it's part of their syncope workup. It's cheap, no radiation. But I want you to hear that you don't have to get the ultrasound. You will because hospital order sets tell you to. And people are still looking at the carotids for the cause of the syncope, but that's not the case. If you've arrived here ruling out arrhythmia, hardcore, yet they still have sudden onset syncopes, then you could go look for neurogenic causes with an angiogram. That first time syncope, person you admit because you think it might be cardiac, comes in to get the ultrasound, a Holter monitor, and the echo. P is psych. That means they are faking it. And if they are faking it, you have to test them to make sure they're not. To do that, use the facepalm maneuver. This is back from my EMS days, all right? Pick up their hand, put it over their face, let go. If they smash themselves in the face, they're not faking it, or at least they're faking it so well that they're gonna get a night in the hospital. If they pull away at all, they're not passed out. There's no reflex that prevents you from smashing your hand into your face. So if you don't, it's because you're awake and you don't want to do that. There's no diagnostic and no treatment. If you find that positive, kick them out. And the last one is to, one, include PE in the mnemonic. I needed an E, but also something to remind you that it's really easy to miss electrolytes. They're not really going to be a history or physical, and you're going to get the electrolytes on a BMP. And remember sodium and calcium for altered mental status, seizures, and syncope, K and MAG for weakness. Right, so this is my approach. Someone says they lost consciousness first time ever, ask about limb jerking, how much, bilateral, and then most importantly, how long did it take them to come back to normal? And then recommend to patients' families, if they don't let the person go to the ground, to do let them, because carrying them around is not helpful. Then work through the history and physical, mostly likely landing at an answer, even before you get any diagnostic tests. And if you decide to admit someone for syncope because you think it's cardiac, get the echo and the EKG. And also get the ultrasound because that's going to be a tough habit for me to break. That's my approach to syncope.